Well, thanks for having me. I'm really pleased to be the first speaker because everybody's coffee should have kicked in. You're probably more lively and awake. So today I'm going to be talking about testosterone therapy, and let's get rolling. So in August of 2014, Time Magazine featured this article here on menopause. The look on that guy's face is probably because it's realized it's a $2 billion industry. Now, it probably doesn't come to any great surprise to any of us that with a $2 billion industry that all these clinics would start popping up. We have Idaho, Connecticut, Oregon, and testosterone therapy can take you from this to this. Now, I don't know about the suntan, but I think I'm not so sure about the muscles either. But we know that testosterone therapy is utilized for such things. So in talking about testosterone, I kind of wanted to look back and see what was the history of this disease. And surprised to find out, Aristotle had actually known about the need for testosterone and what it did. And then in the 17, 18, and 1900s, during the age of crazy medicine, they were doing some experimentation like putting testicles on chickens and putting animal testicles on males. These are true things. But along the 50s, we finally had a true testosterone treatment with the injectable testosterone. Now, for those of us that have been around for a while, we know that the testosterone really didn't take off in the 50s. And we saw this big change come about along with the new change in the millennium. So around 2000, all of a sudden, our offices, probably all of yours, started getting inundated by sales reps with new products for testosterone replacement. And also with the message that docs, healthcare workers, you need to be screening for this disease. It's a real disease and it has complications for it. Particularly they were looking at things like depression, energy level, mood, body muscle mass, even heart disease. They were saying that we need to key in on these patients. He even gave us this great questionnaire, 10 quick questions, and you can diagnose low testosterone. How many believe that? Do you have a decreased libido? Do you have lack of energy? Do you have lack of strength or endurance? Have you lost height? Have you decreased enjoyment of life? Are you sad and grumpy? Are your erections less strong? Have you noticed a deterioration in your ability to play sports? Yeah, I can't slam anymore. Are you falling asleep after dinner? Maybe before dinner. Has there been a recent deterioration in your work performance? Well, my new boss is sitting in the audience, so she can answer that one. But no, I think realistically, if we look at these questions, a lot of us would say yes to them. And we're not going to treat most of you in this audience for testosterone deficiency, even though you have it. So what happened? All these studies came out, reps were coming in, we have new drugs to treat this, and lo and behold, the JAMA released a study that showed during the first decade of the millennium, prescriptions more than tripled. Probably not a big surprise, right? What I found more interesting is they revisited this in 2018. They studied, or published another study that showed that of those prescriptions, half of them went down. There was a decrease by 48%. So clearly something happened between the first decade and second decade of the 2000s. So what happened? Well, we do know that the drug companies were coming in with all these great new drugs, coming to us saying, use it, use it, use it, treat it, treat it, treat it. And what was the insurers, the people who paid the $2 billion saying? Wait a second. We need to rethink this. We need to make sure that we're treating appropriately. And I think those of us that work in office settings realize that this is a tough drug to give nowadays. You have to have multiple blood tests. You have to have, jump through a whole bunch of hoops, do prior authorizations. So I think that slowed it down somewhat. But along with that, there were some studies that came out that also, I think, made people kind of rethink their use of testosterone from using it like crazy to maybe dealing it back a bit. One of those trials is listed here. I like it because it looks at the 7 things that testosterone is supposed to fix. And sexual function was one of those. So we know that testosterone does affect sex drive. And to some extent, erectile function, although I'm not so sure that that's really true, because we treated patients with low testosterone, and a lot of patients come in saying, you know, I can't get an erection, my testosterone must be low. You fix their testosterone and their erections still are not good. Now luckily we have a speaker in our audience, Jeff Alba, who's going to be coming up after me, who deals with that area of expertise. But clearly low testosterone and sexual function and erections are not completely related. And I've had patients that I've treated for prostate cancer with LHRH drugs who claim that they had perfectly normal erections, and we know that they're at low levels. So physical function, it was supposed to make you stronger, able to walk more. It didn't really pan out in the study. Vitality, did your energy increase? We noticed slight improvements in mood and depressive symptoms, but not so much in energy. Cognitive function, I forgot what it said, no. It did not improve the testosterone. Anemia did improve, so that was a good result that we were looking for. Bone density improved, so that's a good result, something we want. But all of a sudden, the cardiovascular disease that low testosterone was predicting wasn't necessarily proven to be benefited by the use of testosterone replacement. As a matter of fact, there was some increase in coronary artery plaque noticed. So what's our take-home message? Well, I don't know about you, but I'm a little confused here. There's definitely some conflicting data, and surely a strong need for more studies and more data. Luckily, our friends from the AUA, our doctor friends, decided to address this subject, and in 2018 they published an evidence-based clinical guide on testosterone diagnosis and treatment. They were looking at the same things that I just talked about. Prescription drugs nearly tripled. Many men were using testosterone but had no clear indication for the use of it. Some studies estimated that 25% were started on the therapy without ever having testosterone checked. That seems kind of crazy to me, at least starting somebody on diabetic medicine without looking at their blood sugar. And then nearly half had not had testosterone levels checked after therapy. That makes sense? Would you treat blood pressure and never recheck a blood pressure? But this is what's happening in testosterone. Answer 3 of those questions wrong. A third of men didn't meet the criteria, and a large percentage, unfortunately, a large percentage were actually could have used the therapy, didn't get therapy because of some scare about prostate cancer with testosterone supplementation. That's been well disproven. There is no correlation between prostate cancer coming from the use of testosterone replacement. Matter of fact, all men with normal testosterone should be having more prostate cancer. But the cardiovascular events, still a little up there in the question mark zone. As I said, it wasn't evidence-based. This is the evidence that the AUA utilizes from strong, moderate, conditional, clinical principle, and expert opinion. These were experts, so all those things could be allowed. And they came up with these nice algorithms. Now, they're in your handouts. The handouts, by the way, are going to be on the website. Mine are already up there. Some of the other ones are. The rest should be. But chicagometrosuna.org, go to our website, you'll be able to get these handouts. And this is a nice algorithm for how to evaluate testosterone, what tests should be done, when you should use them. I'm not going to belabor trying to make you read that. And then another algorithm was produced on how to treat the disorder. And again, I'm not going to go over that. They also did some looked at the prevalence of testosterone deficiency. And the things I circled here kind of jumped out at me. So we look at the 50-year-olds versus 80-year-olds, and we see 12% and 50, up to 49% of 80-year-olds have testosterone deficiency. We see similar results in another study. The other thing that surprised me is we look at what's the low testosterone. First study, 325. Second study, less than 200. Third study, less than 300. Fourth study, less than 317. Again, kind of similar things in the prevalence data. So my take-home message is, obviously, age is a risk factor. And then there's a lot of variation about what some of these studies are calling abnormal testosterone. And I think that that's what we need to kind of decide what's a good level to call our low testosterone. Two terms that you should be familiar with: testosterone deficiency and low testosterone. They're not the same. Low testosterone, lab value. If you do a lab test on a patient, it comes in less than 300, which is what the AUA decided was their clinically relevant number. You've got low testosterone. However, unless you have signs and symptoms to accompany that, then you have testosterone deficiency. And what are those signs and symptoms? Very similar to the questionnaire, right? You look like that guy. No energy, you can't, loss of body hair, reduced beard growth. I grew the beard just for the lecture. Fatigue, reduced lean muscle mass, obesity. So, I mean, these are pretty common, but I can think of a lot of other things that can cause all this. Partially, I know anybody who's 60 or older, I got less energy and, well, the beard growth's fine, but anyway, a lot of these things can be caused from the aging process, other medical disorders, so we know it's not strictly testosterone. Cognitive signs and symptoms are listed here. I did highlight depressive symptoms because in my experience, the one thing I really have seen a lot of good results with is depression in males with low testosterone. And I have a patient in particular that early on in my career that was on injectable testosterone before all the other things came out. His name was Ricky. This guy would come into the office, and he's like, I got no energy, I feel terrible. And he'd get a shot. If we started on testosterone therapy, he'd come back for his next shot. This guy's like bouncing around. He's just the happiest go-lucky guy you ever met. And I said, well, which is the real you? And he says, this is how I should be. He says, this is my normal. He says, that other guy, he says, that was the monster. He says, I'm so glad you guys have figured out my problem. And he had gone to see, the psychiatrist to try these things. But truly, depression and low testosterone, you should look into it. Sexual signs and symptoms, again, reduced sex drive, kind of a no-brainer. The testosterone drives it, and if it's not there, it's not driving it. Reduced erectile function, it can be related to, if you don't feel like having sex, maybe the erections aren't going to be the best. Take-home message. So now we do have a number. 300 or less is grade B evidence. That's what we should call low testosterone. We have to have 2 tests, though, however, to assure that. And those 2 tests need to be done in the morning because we know that testosterone has what's called a circadian rhythm. It comes up in the morning, goes down throughout the day. So between 7 and 11 o'clock is when you should have the test done. As a matter of fact, those of us that are in practice, the insurance company is going to demand it. They're going to say, I need to see 2 testosterones, and if you send it and it doesn't have the marker on it saying, 10 a.m., it says, 3 p.m., they'll ignore it. They won't even take it. So both have to be low, both have to be done in the morning. And then, with low testosterone, we really need to make sure they have deficiency. So what do we need to add in? We need to add in that symptom scores, those symptoms. We have treatments now, lots of them. Lots of great treatments. So we have patches. They're a place where you see those little purple areas. Put on once a day. So what are the pros of patches? Well, I mean, it's once a day therapy. Gives very consistent levels. And we don't have to worry about getting, spouse to, or partner to partner passing of the testosterone. What are some of the cons? Anybody got an idea? Go ahead.
If you go to a gym or something, everybody's going to wonder what those patches are unless they get them themselves.
Either you quit smoking or you're taking testosterone. You got a patch. And anybody that wears a Band-Aid for a long period of time, or a smoking patch or whatever, they're irritated to the skin. If you occlude the skin, it's going to get irritated. So then the gels came along, and we've got a bunch of those. Androgel, which is a packet of stuff that you put on the same places you put the other stuff on, the back. Axiron, which is put on the axilla. Fortesta, which is put on the thighs. All those are once a day. The Testo, which is in your nose 3 times a day. Anybody in this audience have patients on the Testo? One? Yeah. I mean, that kind of tells a lot. I mean, try to get guys to be compliant with something once a day. It's hard. 3 times a day, and stick it up your nose. I don't know. Testim. I don't know if that's still used very much. It's used the same way. Testim had those of us who remember it had kind of a unique musky smell to it. So you could almost tell a patient using Testin when they walked in your office. And the one on the bottom, anybody use this new drug? I have. So again, all topicals. So pros, what do we think? What's good about it?
Convenient.
So it's convenient. We don't have to worry about that, patch getting irritation to the skin. Anybody else? Thoughts, pros?
Steady state.
Steady state.
Oh, steady state. Yeah, thanks, Scott. Right. It's going to allow us to have a nice steady state. What are some of the downsides? Well, we kind of talked about that person to person. If you don't want your partner to start having to shave like me, you got to be careful that you're not having skin-to-skin contact with somebody. And there was, I think it's urban legend myself, but maybe it's true. Some guy who was, put his testosterone on his shoulders and was giving his kids, not naked, but shirtless piggyback rides, and they went into precocious puberty. So anyway, you have to be careful. So, and then 3 times up the nose it goes. Fortesta kind of helps some of that because you put it between your thighs, but I'm not going to make any comments how that can be transferred. Then they came over the mouth patch where you put a little pellet underneath your gum, and then you change it every 12 hours. Does anybody have someone using that in their practice? One patient came in from somebody else, and we still write the script for him. But again, the pros, we don't have to worry too much about transfer, I don't think. And the cons, irritation to the gums twice a day instead of once a day. And then we have implants and injections. So there's Avid, which is an injectable. It's an IM injection. It's given basically every 10 weeks. The first one you have to give after 4. Testosterone, which is a pellet that you implant, 6 to 12 pellets every 3 to 4 months. And again, the testosterone IM injections that we were giving since the 50s are good for about a week or 2 weeks sometimes. And then we actually have a vendor outside, right outside the door here for Exostead, which is the newest one. It's once a week treatment, but it's subcutaneous. It has this really cool injector that you prime it, you pop yourself, and it injects the needle and puts in the medication. So patients can learn to do it themselves. So what's the pros? Come on, we got an educated audience here. But you got to yell because I'm half deaf. The other half can't hear. Oh man, you're going to make me do all the work. All right, so what about skin-to-skin contact? No, injections are fine. You're not going to have anybody getting in contact with that. Compliance, what do we think? I'm a guy. Guys are not known to be very compliant, so something that lasts for a month, a week, 2 weeks, 3 months, that's great. What's the cons? Most of these you have to come into the office to have done. And those of us that have started to have to sit in doctor's offices like myself, it's no fun. And having to come in, whether it's once a month or every 3 months, it's still no fun. Testosterone, I have seen some of the pellets get ejected, and the Avid has a unique black box for oil embolism. I've never seen one, given a lot of it. But again, you have to have the patient sit in your office 30 minutes after the injection to watch for any signs of difficulty breathing. So we've got lots of choices. So there's our patient. We're ready to tell him which door to try. We can try to figure out maybe what's best for him. So we should start prescribing it, right? We have low testosterone symptoms. We want to prescribe it. We go ahead and prescribe it, right? Oh, come on, don't be afraid. I won't bite. How many think we should? Well, hold the phone. And we talked to the patient about this. Counseling is important, and this was brought up by the AUA. Because, yes, low testosterone is a risk for cardiovascular disease. Tuck that one in your brain. We're going to see that again. It may improve erectile function, but I don't think it does. It will probably improve low sex drive. We know anemia, bone mineral density, lean body mass, and depressive symptoms are going to respond well to testosterone. Good things. But the evidence is inconclusive as how well your cognition is going to improve whether your energy and lipid levels and things like quality of life are going to get better. It's just inconclusive. Long-term effects, if you want to have children, we know you can't put people on this treatment because it'll knock their sperm count out. There's absence of evidence linking testosterone therapy to prostate cancer, so we know it's not going to cause prostate cancer. Inadequate evidence about the risk-benefit of patients who have prostate cancer and go on testosterone. Anybody have prostate cancer patients currently on testosterone in their practice? We have a few. As long as it's treated and they remain stable, our physicians are of the age that they'll go ahead and treat them. And you still have to do all the monitoring that you would do normally. Cannot be stated definitively that it decreases or increases the cardiovascular events, so MI, stroke, that type of thing. So we don't know for sure that, even though we know low testosterone may be a risk, we don't know that treating it's going to decrease that. And we should never forget about lifestyle changes. You know, riding a bicycle, exercising every day, watching our diet. Those things help everything. Oh, and one more thing.
You mean shrinkage? Yes! Significant shrinkage.
We need to talk about side effects of therapy. Testicles will shrink if you're on testosterone. It'll happen. I've had a lot of patients, being the nurse, sometimes they won't want to tell the doctor, but I've had a lot of patients go, what's going on? I can't even find the guys anymore. And I go, well, you're on testosterone. It's going to cause them to shrink. And then they're a little bit upset. They're like, well, why wasn't I told that? Well, that's a good question. Let's bring in your doctor and see why he didn't mention that. So I've tried to really make sure that the doctor covers it. You know, sometimes they do. Patients, doctors talk, they turn off the lights. That's why we're fortunate enough to have a doctor-nurse practice. So a lot of times the nurse will come in and say, we're going to start, doctor, why don't you start therapy? Do you understand it can have this side effect? Polycythemia, hemoglobin levels will, it treats anemia, sometimes it overtreats, and your hemoglobin goes way out of normal. That can be a dangerous situation. I've got a couple of patients that I know that we have on therapeutic phlebotomy. They go in and get blood every month or so just to bring their levels down. So it's something that's serious. Again, can't say it enough. If you're trying to conceive, don't treat their testosterone. This last one, I think, is one that doesn't get mentioned and probably should. If you're going to start somebody on testosterone, they need to know that this is a lifelong commitment. That if they suddenly stop their testosterone and they've been on the exogenous form, that it may not come back. So if they were, for instance, treated at 150, maybe 200, let's say 200, so they're kind of low normal. When they stop testosterone, it may be 100 or 50 even, that's castrate level. And it may take a while for that to come back up. And it may not even come up, it may never come up. So it's important that they know that, there is a commitment to this. We do need to follow up with these patients. Very important, we need to measure their testosterone because whatever therapy you pick, individuals have individual results. So you need to see, is it gone up a little? I've seen some patients, go on, Fortesta and they're doing the 4 pumps like it says and their testosterone's 1,000. So clearly it's overworking, so you need to decrease the dose. So dosages have to be adjusted for patients. They should be checked, you need to recheck them. Once you've got a steady state, you know where they're at, they should probably be checked at least once a year, maybe every 6 months. And the last part is really important. I think in that early stage, 3 to 6 months, you need to talk to patients. Has this helped? So, it's great to have their number normal, but if they still are run down and their sex drive is terrible and everything else hasn't responded for what they came in originally for, the discussion should be made, do you want to continue therapy? Because after about 6 months, now we're looking at that possible lifelong results of low testosterone without it. There are other tests, they are mentioned throughout that algorithm, that we can utilize. LH levels, prolactin levels, estradiol, it'll kind of the algorithm guides you to when those should be checked. Baseline hemoglobin and hematocrit, a must. You have to know what they were before they started. You have to know what they did. You know, when we get that next testosterone, we're getting an H&H along with it to see is it having any effect. And we monitor that along with testosterone. And baseline PSA, an absolute must. Although it doesn't cause prostate cancer, if you give a patient with untreated prostate cancer more testosterone, you may as well throw gas on fire. Not fire, gas on fire, yeah. Anyway, don't do it. There are alternative therapies. Anybody use any of these therapies? We use Clomid a fair amount. You know, an oral pill that you can give 3 times a week. It drives the testicles to produce more. And a lot of patients will respond to it. And finally, my conclusions, I do have a list in your handout of the websites that you can go visit if you want to read up more. It's kind of interesting area to look at, you know, testosterone therapy, where it's started, where it's going. So there's more places to get information, read up about it. And I always say when you're ready to end a lecture, you can't go wrong if you end on either puppy dogs or kids. So I chose kids. Those are my 8 grandchildren. The 2 with the S's are from my younger son who lives in Colorado, and the 6 with all the other letters are from my oldest son who lives in Plainfield. And they're what makes life worth living. Now, any questions about testosterone? Yes?
You have to come in the office to get the injectable one, correct?
Prescribed, yes.
Okay.
For instructions on how to use it, but
You
after
can't
that,
pick up any Man magazine or even periodicals that you get in the grocery store or something. Somebody's always got something that's going to help you with your testosterone. You know, just send in the coupon and whatever. So does anybody ever cheat, like they're getting the injections, but then they're using all these creams and sprays and stuff as adjunct therapy?
yeah, so the question is over-the-counter testosterone products that are available on the internet, how much people are using them all. And first of all, a lot of patients won't tell you the truth. They're using them anyway. I mean, I can't tell you how many patients that were on some prostate pill that had sal palmetto while they were taking finasteride. It doesn't make a lot of sense. But patients will self-treat. And they'll complain about their $30 copay, yet spend $75 on some crazy over-the-counter medication that promises they'll look like that guy with a nice suntan. Yeah, it happens, and you know, all you can do is try to get patients to be as truthful as possible. They've got the most to lose by not. No other questions? Great.